We were specifically asked, really, as the CLN, to talk about the Enhancing Mental Health Resilience programme that we've been running this year since the COVID pandemic. But on that, we're also going to touch a little bit about the NHS CLN, because some of you may not be fully aware of its presence and how it functions and what it does. And the work that's then spun off in the Northwest with that resilience programme across 14 trusts, 20 hospitals that volunteered to do that. So if you could move the slides on for me, Suzy, I'll just take us to a bit of history first. The CLN, and Joe Rafferty knows this because he was in at the beginning of this. It started around 2005, 2006, and it existed with the double helix logo as a purpose, a process and a programme for developing shared leadership between clinicians and managers in order to meet, at that point, NHS strategic vision. So it was a joining together, a way of finding how we could get clinicians and managers to work more effectively, to become more engaged, to become more empowered, more enthusiastic, and deliver significant change, and also influence policy and processes. We did that. And a bit like John's saying, we shaped it definitely around common purpose. And it was around the patient and the client experience as it was being described then. And we did this at local, regional, and national level in a number of ways. So that's from 2006 we started this. If you could do the next slide, Suzy. So the thing about the CLN is the NHS CLN it's the only organisation that is actually truly multi-professional. It covers all the clinical groupings of all the types of professions that we have. It of course covers all organisations from both clinical care and now also including social care. And it works constructively. Not only its not members are not only clinical, they are in fact managerial as well, who engage with this. And as Suzy knows, she leads a national programme for what we call the associate model, which is to bring in professional managers into the organisation on a formal basis associated with provider organisations. We do a number of things. We develop clinical leaders and social care leaders, and we do that with programs. We run development programs, work hand in hand with people like the Leadership Academy. And in the last 2 to 3 years, we've been running those programs for emerging leaders from both the NHS, clinical and managerial sector, emerging leaders in those organisations, and also the emerging leaders through social care. With social care organisations and both in the community and obviously on regional footprints and local area footprints, and with an aim really to develop those relationships and those understandings between those people, because the good chance in 5, 6, 7 years time they will become our board members, and we're hoping that those bonded relationships that they've learned through our programme will undo and unlock some of the issues that we have. We also influence national policy. On many occasions, we've had people down from the Cabinet Office and from the Secretary of State to our programmes and their various directors influencing and developing a number of programmes since 2006. We try and improve quality and productivity. We always try and deliver patient client-centred services. That is our common purpose that everybody seems to bind around, out with politics. And we promote shared leadership with the system managers. So in essence, that's in a nutshell, very quickly, what the CLN does and why it formed back in 2006. You have the next slide, Suzy. Now, to do this, we've, over the years, developed a standard operating model that pulls together network theory, large-scale change theory. We practice a lot of the processes that Joe was talking about in terms of getting his empowered organisation without punitive attitude. We use a lot of that stuff. We promote disseminated leadership across the whole system. We see leadership as not only board level, but at every level through the organisation. And we engage and use network theory, whether they are formal or informal networks, both within organisations, but more importantly, across organisations, particularly and local communities, and as it's now called, place, because we understand that the client or the patient's journeys cross organisational boundaries and have issues to do with them that are not defined by the work that we do within single organisations, but across organisations. As part of this, as part of the leadership and engagement, we developed from the standard operating model, a belief model to develop that belief in those individual people, to get them engaged, to get them enthused. And then from that and the way we work, we develop a social movement that both travels within an organization, but also out with organizations across areas, across footprints. And also it does that with the intention of being trans-organizational and on a horizontal, both across at board level, but actually within the system at the lower levels, right down to our most junior people, by engaging them. And we now have about 5,500 members across the country, although that's rising now with social care. We're probably up to probably nearly 6,000 now, and it's rising rapidly. Can I have the next slide, Suzy? So that was a snapshot of what the CLN is for those people that don't know. Some of you do know, but some of you don't. And we came at this from March 2020. We were doing all our product range. We were developing primary care networks with Health Education England. We were running our leadership programs, but everything we were doing was based on face-to-face contact. We did action learning sets a lot to achieve a lot of change. And then the lockdown came. And everything that we did came to a grinding halt. Plus, we weren't really up to pace at that point, probably as the whole country was, with anything to do with COVID and pandemics. So the board of the CLN got together very quickly within a week of this all happening and said, what are we going to do? Because we're going to be stymied now. The department and the cabinet are having daily meetings with the country over the TV about what needs to happen and what the health service needs to do. What do we do? And we recognised at that point that the organisations within the NHS in particular, there was a snowstorm of emails going on. Everybody was rushing around trying to redeploy services, develop Nightingale centres, look at the way that they were running their organisations and what they had to respond to from Cobra and Gold Command. And what we didn't want to do was just add to that snowstorm that would just create more pressure for the people that were already pressured. So we did several things. First of all, we decided we needed to develop a digital operating strategy completely because everything we were doing was based around email and face-to-face communication. So we did that, and within 3 weeks, we'd come up with a digital operating model using a whole variety of products in an integrated way. We then looked at how we could nationally respond. And to achieve that, we did several things. We worked with the National Health and Wellbeing Cell around COVID, and Sonia Wallbach and some of the other cells that were moving. We decided we would not do anything operationally that was to do with deployment of services, because that was going well in hand. But what we did do is we went and looked at all the literature that was coming out of China and Italy at that point. So we're at the end of March, early April now. And what we discovered that wasn't being mentioned at all at that point was the mental health effects on our frontline workforce, on the high levels of morbidity, mental health morbidity and absenteeism in China and Italy were quite astounding. And that was affecting their ability to respond to the pandemic at that point. And we weren't discussing that then. So as a CLN, we thought we could do something about this because we're multi-professional and because we span the country and we have a number of leaders and connections. We decided we'd do two things. We would form a high-level steering group to look at seeing if we could decide how enhancing the mental and health resilience of our staff could be enhanced in an attempt to reduce some of the morbidity that was going to undoubtedly occur. But if we could flatten the curve a bit, try and keep some more people healthy by enhancing their resilience, that would be a good thing. And to do that, I ran around the country and I got together very quickly, and they were all great. They all said yes to do this on a voluntary basis, a high-level steering group, of which Joe Rafferty was involved in this, to design and come up with a paper that was authored by one of our CLN members, who was an emerging leader, a liaison psychiatrist called Coley, who has since then gone on to do a number of good things. And be supported by this steering group with some of the great and good across the country who represented professions, but also knew a lot about workforce-related stress, and also were experts in the professions that they came from. And within about 4 weeks, using library services to do assessments of both international pandemic planning and also experiences from armed forces and other people that have dealt with situations that were difficult like this, we came up with a paper that was called a call to action. And it was a description of what this group thought good would look like for an organization if it was to provide the best of support for its staff in an attempt to enhance their mental health resilience of the staff that they had under their employment. Could you go on to the next slide, Suzy? And as you know, and what was becoming clear at that time from both our groundwork of doing ward walking with our staff as we were writing this paper, but also from the international evidence and from the documentation that was coming out of our professional organisations nationally, high levels of mental health related illness, and frighteningly, quite high levels of symptomatology that would suggest that PTSD was going to become a significant issue within the workforce. And obviously that's a delayed condition and can take 2 or 3 months to become really apparent. And also this new concept of moral injury, which I'm sure a lot of you know about, and we'd learned a lot from the armed forces about moral injury and the nature of our pandemic and what was happening with our staff and trying to treat these people in the front line, both in the community and in hospitals and in intensive care, was causing an issue with moral injury as well as anxiety and depression. So what was happening was being seen to happen and had been described in the China and Italy experiences ahead of us. If you can have the next slide, Suzy. So we wrote the paper. We took the paper out to national publication. It got published widely. It was on BBC, Guardian, Independent Local Radio. It was in the journals, the academic journals, in the HSJ, which got a good coverage. And it fitted well with what was trying to be done through the national cells around health and wellbeing and within the organisations across the country and how they were trying to rapidly respond. A lot of them were responding using their own experiences rather than there being anything tied together well that was written into any kind of pandemic planning that gave you a heads up for this. So we did that, got good coverage, got phone calls from all over the country as an organisation about the product, about the paper. And the board, on the back of that, we got to now May, end of May, early June, said, what do we do now? And we thought we could activate this programme, we could activate this paper and see if we could find in one region how many organisations would like to volunteer to work with us on a response for the health and wellbeing resilience in provider organisations and work with them about how well you respond. We would then look and take our paper that we'd written and reflect that to the organisation and to learn from that organisation about what they were doing that we hadn't even thought of that was good work. Evaluate it against sitrep data, evaluate it against absenteeism and presenteeism data, and things like the NHS staff evaluation summary. And also we looked at a series of structured interviews across the organisations, and we would pull all this information together and commission Manchester University to help write us up academically with a view to this coming out later this year and go back to NHSE and to the Cabinet Office as a region's response to the health and wellbeing issue, and possibly evidence of what worked well and what didn't work well in an attempt to inform any future pandemic planning that would be written up as for hopefully to help us do a better response for the future when we do get a pandemic again, which will occur at some point in time. So that's where we came from. That I won't go into detail because Suzy's going to touch this, but it was divided into individual support for the staff on the ground, this programme, using a variety of techniques around using our digital action learning sets across organisations rather than just in an organisation, from those 14 trusts, those 20 hospitals. And we developed a tool called C19 Asset, which was a spin-off of an international assessment tool on work-related stress, but we COVIDified it, we added C19 to it. We were going to attempt to do organisational alignment, and within that organisational support, reflect on our call to action paper with HR directors and the health and wellbeing leads, and then an intervention evaluation, which we had a committee, a metrics evaluation committee headed up by Professor Sakari Cooper, who's an internationally renowned expert on health and well-being in the workplace and workplace stress. And Suzy will go into those in more detail in a second. Next slide, Suzy. And that we would offer this to the volunteer NHS trusts. This wasn't a line management thing, even though we were doing it in combination with NHSE. It was a voluntary thing. And we went to in the region, this Northwest region, the STP footprints, the partnership boards, and all three partnership boards in the region commissioned us to put together a team to make this pilot program effectively work. And we used a combination of resources in terms of money, but also redeployed staff and staff that had volunteered themselves as being extremely interested in trying to work with us on this program. And we helped with the resilience program. I won't go into this next slide in any detail. When you get the slide packs, it's worth a look though. This is what we produced to try and help trusts to a self-assessment about where they were up to with their own pieces of work, early doors, before we went full blown with the program. So it was an early piece of a self-assessment tool to help them with that. Next slide, Suzy. So that was just a very quick high-level run through of where we were, why we came to this, what our skill sets were, but Suzy will go into more detail about the actual program and what's been happening.
Thanks, Andy. I've got about 5 minutes, so I might skip through a few of these slides, but like I say, you're going to get the pack, so hopefully you can get some more of the detail. So in terms of the three kind of main products that we've been offering, the COVID-19 asset tool has been designed for frontline staff. It's been based on the asset tool that's been around for several years and is used internationally. It's a web-based tool, it's all anonymised, but it does provide individuals that personalised snapshot report that gives them an insight into their own emotional health and well-being, and also provides them the opportunity to tap into the local resources that are available to them. But on the flip side of that, it also provides us as a programme, and which we can feed into the regions, that really invaluable analytics, which there's a screen in a minute that can go through some of those early indicators. This is how it's set up. There's 6 core questions that are part and parcel of the original asset tool, but there are those specific questions that we've put in there from a COVID-19 perspective. And also we get some really good, valuable demographics, so we can delve into about the people that are answering that, and how we can split that up as we move into the analytical area. So I'm not sure how well you can see this on your screens, but all the red bits are the bad bits, as you'd imagine. This is a snapshot, it's an interim snapshot of some of the results we'd got back at that time. So we are going to be publishing a more detailed report shortly. I think we're closing the access to the asset tool at the end of this month, and we'll be having those reports in April time.
Yeah, these were by November, Suzy.
Pardon?
This was by November, this data set.
Okay. And so what it does show, early indications, is actually, if you look at the physical and psychological health, that is the most adversely affected area across all professions, across all areas within the organisations we've been working with. If you look as well, those front face-to-face clinical services, there's a significant amount of people that have responded from those, and again, a significant amount of impact they've had from a physical health, psychological health, and also having that psychological well-being perspective. So really powerful indicators there that as a group of staff across the NHS that have accessed this, there is some quite a lot of areas below the norm that you'd expect to see within an organisation. And then similarly, results across specific staff groups are very, very consistently poor across these physical and psychological health perspectives. But more specifically, if you look across the medical and dental staff, actually they do produce the most challenging results. So again, it's a snapshot. We are going to be pulling together this in a bit more detail in the winter of this year. Some of the key findings that we've got from the additional questions in there, again, from that snapshot, are really quite powerful. So we've got 86% saying that COVID-19 has made them feel burnt out. 64% are overwhelmed with what's expected of them at work. 80% feel that their job places their families at risk of COVID-19. On the positive side, 88% feel that they've got the appropriate PPE that they need, but obviously there's 12% that don't feel that. And 69% have shown presenteeism at least once during the last 3 months. So again, it's an interesting view into what's happening to individuals, to the people that are delivering our services and supporting the delivery of those services across the NHS in the North West. So supporting that, we're doing some qualitative work as well. So we've done a series of HRD and health and wellbeing team structured interviews that are based on the recommendations for the call to action. So we've been working with them around the wide range. So that kind of the graphic, that was one of the last slides Andy showed, that we have a series of questions around that. So that all feeds into the kind of the qualitative element of the data. And then supporting all of that then is the digital action learning sets. There's a slide there that just talks to you about the principles of action learning sets and how we've applied them. We've digitized that, so we have a series of Teams meetings that we hold with our action learning sets that are facilitated by our very valued volunteer associates in the programme. Other data that's coming in, so we've got the SITREP data from the workforce data that's produced nationally. We've got trust in-house absenteeism data that specifically pull out some COVID-19 specific information. We've got the NHS staff survey and the NHS people pulse. So all this streams of quantitative and qualitative data are coming into the research team to churn through and produce something which we hope will be really valuable to the system moving forward. This is some of the SITREP data. Again, it's quite an interesting slide, but the key thing to recognise here is that the percentage of sickness days due to anxiety, stress, depression and other psychiatric illnesses actually hit a big peak about 2 to 3 months after that first wave. So it just shows and provides the evidence that this is something that happens after the wave. So again, we'll probably see something very similar that in the next couple of months following this second wave. Again, it's challenging data to look at, but it helps bring us a broader picture in terms of the impact this is having. So I think this is my final slide. This is about what our sensational 6 actions are as a clinical leadership network. This asset tool, it's a gift to the frontline staff. We've had some fantastic funding to support that. It's there for staff to access and provide that personal insight as well as the invaluable strategic analytics. All the actions in-house, we've had some great stories today from some of the speakers in terms of what's happening within organisations, what's happening across ICS regions, but that's all really important and really powerful to kind of feed into it. Leadership, again today we've heard some fantastic leadership examples of how we can develop that kind of offer and make sure that we've got a really solid belief model and social movement to support this. And we really promote the culture of compassion. We want the organisations to embed that civility and the actions to mitigate against compassion fatigue, which I think is being felt across the system as well at the moment. The freedom to design their own bespoke offerings is also really important. So the national and regional offerings are kind of essential, but having the opportunity to develop what's needed for that organisation or that system is critical. And we'll continue to mobilise and expand on our digital action learning set model to support transformational change. And as an organisation, CLN is looking at developing their regional franchise model to help this across the rest of the country.